this video is about the definition and predictors of difficult airway. The very important thing that you should remember, why at all are we conducting airway examination? This is to rule out the predictors of difficult airway. Right? That predictors of difficult airway can be found out based on history or examination. Now, what do you exactly mean by a difficult airway? Difficult airway, according to the ASA, it includes the clinical situation in which anticipated or unanticipated difficulty or failure is experienced by a physician trained in anesthesia care, including but not limiting to these following factors, that is face mask ventilation, laryngoscopy, supraglottic airway, intubation, extubation, or invasive airway. So that this is exactly the sequence that we have to a person has to undergo, starting from the face mask ventilation till if it is cannot intubate, cannot ventilate situation, that then have to undergo invasive airway. So every single step, if there is a difficulty, whether anticipated or unanticipated, is difficult. Now I have a mnemonic for all of these individual difficulties, and this is something that a person as an anesthesiologist has to remember lifetime. For the bag mask ventilation, there's a mnemonic called MOANS, MOANS. There's another mnemonic called BONS, which is very similar to MOANS. What are the components? If there is a difficulty in the mask seal, if there is some obstruction in the airway, the patient is obese, if the age, if they are elderly, and then if there is edentulous patient because there will be leak around the mask, and if the person has less compliant lungs, that is stiff lungs, or again because of obesity, if they have pulmonary hypertension and their lung fibrosis because of sleep apnea, all those components will be increasing the resistance to the airflow. So that resistance will lead to more of the leakage around the bag mask. These are, so you have to remember and for this lifetime. The second component is supraglottic airway devices. The mnemonic is RODS, RODS. That is restricted mouth opening. Because if the mouth opening is restricted, how will you insert a supraglottic airway device, right? Then again, obstruction, any distorted anatomy, because if there is some distorted anatomy, even if you insert a supraglottic device, there will be leak, and again the stiff lungs. Then we come on to the laryngoscopy. The mnemonic is LEMON, LEMON. So you have to look externally. What do you mean by look externally? When we'll do the airway assessment, there are certain characteristics like retrognathia, if there is some facial trauma. So yeah, on looking externally, you'll be able to realize that this is a difficult laryngoscopy. Then we have a rule 332 evaluation. This will understand in airway assessment that there are certain distances that if you measure, then you will be able to understand if it is a difficult or easy laryngoscopy. Then we have Malampatti, or known to all of you, and again obstruction, obesity leads to difficult laryngoscopy. And if there is limited neck mobility, if the patient is not able to flex or extend his neck, the range of motion is limited, then, because as you all know that for intubation we need a sniffing position, and you will not be able to attain that position because of the restricted neck mobility. So these are the factors for difficult laryngoscopy. The last one is difficult front of neck access. If you are not able to intubate and ventilate the patient, you may have to go for the FONA. The mnemonic for this is SMART, SMART. So if there is some surgery, a person has undergone any neck surgery, neck dissection or something, any mass is present like thyroid mass, and if there is difficult in the assessing the anatomy, if there is some radiation exposure, and if there is some tumor, so these lead to difficult front of neck access. So these are the predictors that everyone should remember. We'll discuss the airway assessment as such by demonstrating it on a volunteer. See you in the next video on airway assessment. Thanks for watching.